Okay, I am back. We're about to continue. Raise your hand if you can hear me. All right. Okay, that's good enough. Right, so before we go into lifting and moving, I'm just gonna run through a radio report format. It will be available to you on the platform, but I'm just gonna run through a format. All right, so attached, and you may have to zoom in on the document on your end. Attached is a format for giving a radio report. So 1, identify the facility you are calling and your unit or organization. So UE Hospital, this is MedStar unit number 20, ALS response. Are you receiving this transmission? 2, then identify the patient and the chief complaint or working diagnosis. We are en route to your facility with a 39-year-old adult male patient with a complaint of difficulty breathing with a history of asthma and no current medication. Then give notable findings. So number 3, then give notable findings and treatment. Patient is alert and oriented to person, place, time, and event, presented with respiratory distress and labored breathing with wheezing on expiration in the bases of the lungs bilaterally. The patient is currently on high flow O2 at 12 liters per minute by a non-rebreather and will be receiving a neb treatment with Ventolin and Atrovent at 6 to 8 liters per minute shortly. Number 4, give the current vital signs and GCS. Current vital signs are as follows: pupils pearl, respiration 28 breaths per minute, O2 sat 96% on oxygen, pulse 106 beats per minute, temperature 96.8 degrees Fahrenheit, GMR 84 milligrams per deciliter, BP or blood pressure 116/74. The patient has GCS of 15. GMR is glucose monitor reading. Time you will see EG, random blood glucose. Number 5, step 2, keep in mind, then give specific resources if needed on arrival. For example, patient will require evaluation by a pulmonologist on arrival, or patient will require a respiratory therapist on arrival. Give estimated time of arrival, ETA 10 minutes. So this is a format. It doesn't have to be exactly like this. There are other formats that can be used. I'm just giving you an example of what it would look like. So that's radio report. Now, every participant within this course must be able to do a written report and a radio report. So that will be a requirement in your final evaluation. Let's go to lifting and moving. So that's chapter 8, lifting and moving patients. So EMS is a very physical job. You're required to be in good physical shape, being able to move your patients without causing injury to yourself or your partner. And you have to move around a lot of equipment. So Proper techniques for moving patients and procedures is essential, and you need to keep yourself in good physical shape. And so exercising is important, and it must incorporate aerobics, strength training, and flexibility. So whatever routine you're using. So find something. If you haven't been doing that, find an activity and exercise. For me, it's martial arts. So as long as I've been doing EMS, I've been doing martial arts. It doesn't have to be martial arts that you use for your exercise routine. You can use something that is less risky, right? But you need to be in great shape to handle the weight of patients. All right, now in the course of a call, you will have to move patients to provide emergency medical care and transport. To move patients without injury, you need to learn the proper techniques. You need to learn proper body mechanics. So knowledge of proper body mechanics and power grip. And a power grip is the palm upright, right? So when you grip with the palm pointing upwards. That's what we call a power grip. The wheel ambulance stretcher is going to be your primary equipment. It's sometimes referred to as the gurney. So it's going to be your most commonly used device, and it weighs about 40 to 145 pounds, right? You must be able to manipulate the wheel ambulance stretcher with a patient on it, with the combined weight equipment of, I would say, 250 pounds. So you and your partner must be able to manipulate that stretcher with 250 pounds on it. And depending on where we do the face-to-face, when you come for face-to-face, that will be a requirement to pass this course. So if you cannot manipulate the stretcher with weight on it, I will not be able to pass you as an EMT. So you must be able to manipulate the stretcher with weight. So the wheel ambulance stretcher weighs 40 to 145 pounds, generally not taken up or down stairs, where the patient must be carried for any significant distance. And once the patient is on the stretcher, let me use my pointer. The head of the patient would be right here. The lower extremities would be down here. Now, when we're going to move with the patient on the stretcher, we move with the lower extremity portion first. So we pull and pull. Sorry, push from the head and pull from the foot. So the patient must be able to see the direction that they're going in. They're responsive. When we're going to load the stretcher into the unit, the stretcher goes head first. But when we're traveling with the stretcher, we travel foot first, or feet first. Moving a patient by rolling using a stretcher or other wheel devices is preferred when the situation allows and helps prevent injuries from carrying. A number of models are available, and there are some pretty cool models now. When I just started in EMS, the stretchers that were being used back then could only go all the way down and all the way up. So we had to lift the stretcher with the patient to put it in the unit. That's not the case anymore. You have stretchers that can load themselves. You have stretchers that can go to various levels. In Jamaica, I don't know what is out there. I've seen the old type. stretchers that I was using way back in the days, and I've seen the stretcher that we can adjust to different height, but there are more sophisticated stretchers that you press a button and it moves, right? Don't know when we'll get to that stage, wishful thinking. So a number of models are available. Before going on a call, familiarize yourself with the specific features of the stretcher and your ambulance carries. So you need to be familiar with the type of stretcher that you're using, and you need to know when to anticipate weight on the stretcher. So some of the manual stretchers, you have to release a lock, and when you release the lock, the weight comes down. So you have to anticipate the weight coming down in your palms, as the stretcher will drop out of your hand. Now, general features: head end and foot end. Strong metal frame to which all other body parts are attached. Hinges at the center allow for elevation of the head and back. They have guardrails to prevent the patient from rolling off the stretcher. Undercarriage frame allows adjustment to any height. Mattress must be fluid resistant. The patient is secured with straps, and it helps protect the patient from further injuries. So that's the primary equipment for moving patients. Now let's look at some other equipments. You have your backboards. You have your long, flat, and made of rigid. It's long, flat, and made of rigid rectangular material, mostly plastic. It is used to carry and immobilize patients with suspected spinal injury or other trauma. Now, the backboard that is being used for spinal patients is a scoop backboard. So it's not the backboard that you're seeing here. Backboard that is now commonly used is a scoop backboard that can be pulled apart, because we're moving away from spinal immobilization and doing what is referred to as spinal motion restriction. Further down in the course, I'll discuss the difference. I will have to teach you the two approach, because the current curriculum doesn't reflect the most recent changes. The current curriculum is still using spinal immobilization, but the most current changes being practiced in EMS services across the world is spinal motion restriction. Now, apart from putting a patient with suspected spinal injury into your unit, the spine board can also be used as a flat surface if you need to do CPR for the patient. You can't do CPR on a patient on a soft surface. You need a rigid surface under the patient. So the spine board can be an option, or a sharp backboard can be an option. Commonly used for patients found lying down. It is used to move patients out of awkward places. It is 6 to 7 feet long. Holes serve as handles and place to secure straps. When you move a patient, take care that injury does not occur to you, to your team, and to the patient. So when you look at a patient, and I always tell persons, hey, if you cannot stretch your arms across a patient and touch the opposite side of that patient, you're gonna need a lot of help to move that patient. So if you can't reach across them and touch the opposite side of the patient, you're gonna need help. And if you look at the patient and you believe that this patient weight is greater than your weight combined with your partner, you're gonna need help to move that patient. So don't attempt to move a patient if you clearly cannot manage the weight of the patient. Patient lifting and moving are technical skills that require repeated training and practice. Now, when we're lifting and moving patients, under no circumstances you will be using your back to lift the patient. You lift with your legs, so your back must always be straight, right? So at no point you should be bending your back to pick up any weight. Your back is not designed for that purpose. So your legs are designed for weight bearing. That's where you're gonna use to lift and manipulate weight. Many EMTs are injured lifting and moving patients, and this can end your career. Use proper body mechanics and maintain physical fitness, right? So using proper body mechanics and maintaining physical fitness greatly reduce the chance of injury. So you need to be in good shape. If you're not, start thinking about it. Now, anatomy review. You have your shoulder girdle, your spinal column, pelvis, and the legs. And as I stated before, your back is not designed for lifting. So the muscles in the back and the spinal column is not designed to bear any type of weight. Your pelvic region down to the legs is designed for that purpose. So when you make the attempt to move the stretcher from the ground upward, once you go down, your back must be properly aligned. So your back shouldn't be bending, right? And when you come to the face-to-face session, these are things that I will be looking out for. And if you cannot do it, I will have to remove you, because I'm not going to make anybody injure themselves. Now, before I go any further, if there is anybody in the group that has any physical limitations that will prevent you from lifting and moving the patient, ensure that you relay that information to either me or Mrs. Mackay via email. So do not come on the day of your face-to-face to tell me that you have bad knees or you have bad back and all of that. From now, if you know that you have that type of issue, do up an email, send it to me, send it to Mrs. Mackay. Okay? Now we'll figure it out. Now, lifting position. When you're lifting, key things that you need to keep in mind: you must have equal distance between your arms. So you need to have equal distance between the arms. You don't want your arms stretched out fully, because once the arm is fully extended, it becomes weaker. So you tend to want it more in a flex position when you're controlling weight. So the closer your arms are to your body, the stronger the arms will be. And you want shoulder length distance between the legs. And for persons that are tall, you can put one leg forward, one leg backward. So lifting position, the shoulder girdle should be aligned over the pelvis. Hands should be held close to the legs. Force then goes essentially straight down the spinal column. Very little strain occurs. Right, so this is correct way to lift. And in this picture, I think this demonstrator has too much curve in his back. The back should be straighter than that, right? So you want the back straighter than that. And what you can do to practice that is you can put your back against the wall and squat. So put your back against the wall and squat, and your back should not come off the wall. That is your objective. So you should be able to squat down and your back remain against the wall. You don't want any type of curve in your back. That will mash up your back, right? You may injure your back, and when you have back injury, these are chronic problems. These are long-term problems, right? And you can have serious back problems. You can have disc shifting in the spine and compressing the spine, right? You can have shifting and a compressed nerve that feed muscles, and the muscles are cut off from stimulation and start to shrink. Whole heap of things can happen if you don't protect your back. Now, some service will recommend the use of a back brace, and some people don't even wear the back brace properly. They wear it like it's a jacket. You understand, right? So you're defeating the purpose of the back brace. When you're wearing a back brace, you need to open your pants and put the back brace down into the pelvic region. So you need to wrap around the pelvic region, right? It shouldn't be in the lumbar area. You need to be around your pelvic region. Now, where was I? If you lift while leaning forward, that can cause problems, right? So don't allow the weight to pull you forward. When you lift the weight, it needs to come up. Don't allow the weight to swing you forward and backward. If you lift with your back straight but bend significantly forward at the hips, can get injuries. So let's look at something that's really terrible, right? So this is definitely a no-no. Definitely a no-no, right? It's a recipe for disaster. If you want a long-term career in this field, definitely don't do that. All right, now lifting technique. Legs should be spread about 15 inches apart, that shoulder width. Place feet so that the center of gravity is balanced. Always know where your center of gravity is. With your back held upright, bring your upper body down by bending the legs. Only the legs should be bending. Grasp the patient stretcher, palm up. Make sure you have a good grip. And somebody needs to be giving clear commands. All right. Right. So we're going to lift on 3, 1, 2, 3. Clear commands. And if you are the person responsible for clear commands, look. Right? And if you think that you're not in a good position, hold on. Hey, you at the leg, just fix your grip a little bit. Come on. Good. Right? So don't do anything that is going to cause harm to yourself or crew members. And I've had a rookie let go a stretcher on me with a patient with a DVT. Right? So I've had a rookie that let go the stretcher because it wasn't locked properly. Luckily, that patient wasn't heavy, because if it was a heavy patient, I wouldn't catch it. I would let it fall. And if it was a heavy patient with a deep vein thrombosis, that would definitely dislodge and end up in the pulmonary arteries. Now I have a bigger problem to deal with. It can be the person at the head, or it can be the person that is controlling the lock. So whoever have lock control can also give commands. It's not specifically at the head, because sometimes the lock control is at the foot of the stretcher. So whoever is going to control the movement of the stretcher up and down should be given the commands. The strongest person should be at the head of the patient, or control the heavier portion of the patient. Lift the patient by raising your upper body and arms, and straighten your legs until standing. Keep the weight close to your body. You don't want your arms fully extended. Keep the arms close to the body. And you're utilizing your power grip for maximum force from the hands. So that's palms up, hands about 10 inches apart, all fingers at the same angle, fully support the handle on curved palm. Make sure you have a good grip. When directly lifting a patient, tightly grip the patient when directly lifting a patient, tightly grip the patient in a place and manner that will ensure that you will not lose your grasp on the patient. So make sure you have a good grip on your patient. Now, principles of safe reach and pulling. Body drag. The same body mechanics and principles apply to moving, lifting, and carrying a patient. Keep your back locked by tightening your abdominal muscles. Kneel, extend your arms no more than 15 to 20 inches in front of you. Alternate between pulling the patient by flexing your arms and repositioning yourself. Don't play swing sound with the patient. So the patient is on the bed and you grab the patient and swing them over on the stretcher. Gradually move them to the edge of the stretcher, to the edge of the bed and then over to your stretcher. We don't want to overextend at any point. All right, and that's a form of drug. You have various drugs that you can use to move your patient. To drag a patient across a bed, kneel on the bed to avoid reaching beyond the recommended distance. We don't want to overstretch. Drag the patient to within 15 to 20 inches. Complete the drag while standing at the side of the bed. Use the sheet or blanket under the patient rather than dragging the patient by his or her clothing. So, patient on a bed, use the sheet. I've had some EMTs that recently completed research and I've given them a patient in a bed and they were telling me that they're going to use a spine board to move the patient, which was crazy to me, right? The patient on a bed, use the sheet, man. Move the patient or use a blanket. Why are you going to use a backboard at that point? It just didn't add up in my head. So do what is easiest for you and your crew and best for your patient. In the hospital, transfer the patient from stretcher to a bed with a body drag. The stretcher should be the same height or slightly higher than the bed. You and your partner should kneel on the bed and drag the patient gradually across from the stretcher to the bed. Now, to put a patient on a spine board, a log roll is required. So we have to log roll the patient as a unit, and 4 persons are required to do that effectively. Person at the head is responsible for giving the count. You need somebody to control the upper body and somebody to control the lower body. This 4th person can be on the opposite side to control the spine board, right? I wouldn't have this 4th person at the leg, she's not necessary. I would have her on the opposite side to control the spine board because this patient doesn't look like a big or heavy patient. Someone had typed something in the chat. Oh. The spine board is specifically indicated for suspected spinal injuries. However, it can be used to quickly move a patient from point A to point B if your stretcher is not able to get into that particular space, or it can be used as a hard surface if you need to do CPR for your patient. But primarily, it's for patients with suspected spinal injury. All right, I won't go through the specific technique for that because that's something that we're going to practice in the classroom setting. All right, now principles of safe lifting and carrying. Whenever possible, use a device that can be rolled. When a wheel device is not available, make sure that you understand and follow the guidelines for carrying a patient on a stretcher. And remember what I said earlier. If you cannot reach over to the opposite side of the patient, you are going to need help to move that patient. And I have had some patients, I can tell you that, right? I've had a patient where it's a mini crane. It's a mini crane we had to use to move that patient, right? She was huge, right? So once you look at the patient and the patient weight and your partner weight combined is less than that patient, you're gonna need assistance. So step outside, go on your radio or phone, code Hercules, right? We need some help to move this patient, right? And the patient would need, that particular patient, she refused to participate in any way to assist us to move her. I needed her to just stretch over to her opposite side that I could pull the wait, I don't even remember what's the name for that thing, but I needed to pull the canvas underneath her to the opposite side, and she wouldn't stretch over, right? She just in at the bed, looking at us, trying to work a miracle. So you will have some patients that are heavy, right? Heavy. And you're gonna have some patients that are ridiculously strong, right? Ridiculously strong. And we'll get to that when we look at restraints. Now, the patient weight. Estimate the patient's weight before lifting. Adult often weigh 120 to 220, right? And you should be able to manage your own body weight. If you can't do that, you're gonna have some problems. So make sure you can manage at least your body weight. In Jamaica, bariatric patients or patients that are overweight is not very common. You will encounter them every now and then, but it's not common. It was very common in while I was working in the States. Majority of the patients I transported were overweight, over 200 pounds, close to 300, over 300 pounds. That's very common in the States because of their eating habits and the processed food. And food is cheap over there. Food not cheap out here, and the sun always upheld the average Jamaican, right? We are hustle. So we can't eat all of them processed food that we can't afford it here. So Jamaicans tend to be more leaner, right? But since the pandemic and persons have to be at home more, at a weight have been packing on, right? So we need to start working out again, myself included. So 2 EMTs should be able to safely lift this weight. So you and your partner should be able to lift 250 pounds without any complications. Try to use 4 providers to lift when possible. More stability, and it requires less strength. So don't be afraid to ask for help. We're not supermen and women. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. And you may need more than 4. You may need more than 4 persons. Know the weight limitations of the equipment and how to handle patients who exceed the weight limitations. And in the States, they had a unit specifically for that. So they actually had a bariatric unit with a special stretcher, a wide stretcher in the States. Now, lifting and carrying a patient on a backboard or stretcher, more of the patient's weight rests on the head half of the device than on the foot. So we need the strongest person at that end. You can use the diamond method. I am not a fan of the diamond because I will do it as long as I am not the person at the foot, because I feel very awkward in that position. So I'm not a fan of this. I prefer two, one person on this side, one person on the opposite side at the head, one person on that side, and one person on the opposite side at the leg. So I prefer two persons on each side when I'm carrying the spine board. I don't like the diamond carry. It's very uncomfortable for the person who is controlling the legs. Use 4 providers. Okay, we're not going to go through the skill part of it. These are things that we will practice face to face. Now, moving a patient with a stair chair. So you may have a patient that is upstairs and the patient is not able to walk, and you need to get them downstairs, but they are able to sit upright. Use a stair chair to carry a conscious patient up or down a flight of stairs. This lightweight wheeled folding chair has a molded seat, adjustable safety straps, and fold-out handles at both the head and foot. And you may have to improvise in Jamaica. Now, the truth is your unit should have a stair chair, but I know that majority of the ambulances operating currently in Jamaica does not, even if they say otherwise. So you may have to use a chair that is available at the patient's home, and you may have to put some straps on it. Use straps to secure the patient. So you should always have backup straps on your unit, right? For that purpose. Now, to utilize a stair chair effectively, you need up to 3 persons, right? Somebody to control the upper portion of the stair chair and someone to control the foot end. And then you need a spotter. We call them a spotter, who will be behind the person that is controlling the leg to tell them when to step, 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 hold on, make some adjustment, step. Now, if the patient is unresponsive, then we have a problem, right? Because we might not be able to put that patient in a seating position. So a backboard should be used instead for a patient who is unresponsive, who must be moved in a supine position, who must be immobilized. And I have had to move some patients on a spine board in some spaces. I don't know how and why some of these persons design their homes like that, right? I've been in a walk space where I can't square up. I can only move sideways. Ridiculous, right? I've been at a location where it's a hillside. Yeah, we ended up using rope to control the stretcher coming down to the ambulance. It can get real crazy out there. Real crazy. All right, not gonna go through that skills again. And the principles are gonna be the same once we're moving a patient. Strongest person control the upper portion of the device that you're using to move the patient. You need an optimum number of 4 or more persons. The more persons you have, the better. And ensure that your patient is properly strapped to the device that you're using to move the patient. right? Loading a wheel stretcher into the ambulance, ensure the frame is held firmly between two hands so it does not tip. Newer models are self-loading, and that's the one I prefer. I prefer to just roll it up to the back of my unit and press a button and it just go up and go in, and I am doing nothing. That's what I prefer, right? However, that doesn't exist in Jamaica, so you may have to do some amount of lifting to get it into the back of the unit and then lock it into place. Other models need to be lowered and lifted to the height of the floor of the ambulance, and you have clamps in the ambulance that will hold the stretcher in place. Do not leave around the back until you hear it lock into place. It needs to lock into place, and when it locks in, check it, right? So see if you can pull it out when it locks in place. Can't pull it, then it's firmly in place, right? So if you rock it and it doesn't fly out, then it's properly secured. Directions and commands. Team actions must be coordinated. So you need to have a team leader. Indicates where each team member should be, rapidly describes the sequence of steps to perform before lifting. Right? Preparatory commands are used. Team leader says, all ready to stop. To get team's attention, team leader says, stop, in a louder voice. Countdowns are also used. Use whatever you're comfortable with. Carefully plan ahead. So you think about what it is that you need to do and how you're going to do it. You may have to think outside of the box. Select the methods that will involve the least amount of lifting and carrying. Consider whether there is an option that will cause less strain. Now, emergency moves. An emergency move is necessary when you arrive on a location and there is danger to you, the patient, and your crew. So you need to move them quickly before doing any type of assessment. Let me repeat that. An emergency move is necessary when you arrive on scene and there is something present on that location that is a potential danger to you, your crew, the patient. So you're going to move that patient quickly before you even start to assess the patient. Now, the emergency move can also be used if I come on a scene. So I arrive on a scene of a motor vehicle accident and I open the door. The first patient or the patient that's closest to me, nothing is wrong with that patient. That is significant. But when I look past him, the patient that is beside him or on the opposite side seems to be more seriously injured. I can use an emergency move to move the first patient out that I can get to the one that is critically injured. Now, in the field of EMS, all drugs are emergency moves, whether it's arm drag, underarm drag, closed drag, firefighter drug, all drugs are emergency moves. My slide is not moving forward. There you go. If you are alone, use a drag to pull the patient along the long axis of the body. So try and keep the patient as straight as possible. Use techniques to help prevent aggravation of the patient spinal injury. So you have closed drags, blanket drag, which is my favorite, arm drag, and then you have arm to arm drag, and I like the underarm drag as well. So you have various techniques. Use whichever you think is appropriate right? So I'm a big fan of the blanket and the underarm drag. Closed drag, it depends on the type of clothing that the patient is wearing. The arm drag, I'm not a fan of that because that can put a certain amount of strain on my back muscles. I prefer the underarm drag because the patient is close to me. So it's easier. My arms are closer to me. I can generate more strength in my arms than when my arms are stretched out. So any technique that allows my arms to remain in a flex position, I am a fan of that technique. My underarm technique is a bit different, and it's different because of my martial arts background. So I do it a little bit different. And I can show you that variation when we meet face to face. All right, already told you the reason. So to remove an unconscious patient from a vehicle alone, move the patient's leg, clear off the pedals, rotate the patient so the back is towards the open car door, place your arms through the armpits and support the head against your body and drag the patient from the seat to a safe location. Now, obviously, if your arms can't reach around the patient, it can't be done, right? So it's if you can manage the weight of the patient. All right, now an urgent move. So an urgent move now. An urgent move is necessary when you come on scene and you have assessed your patient, but the patient ABCs are compromised. So the airway, breathing, and circulation is compromised, but the position that you find the patient in, you cannot manage these areas effectively. So an urgent move is necessary at that point. For example, I arrive on a motor vehicle accident scene. I approach a patient in the vehicle. The patient's airway, breathing, and circulation is compromised. But the position that that patient is in, I cannot effectively manage these areas. At that point, I will do what is called, or my team will do what is called rapid extrication. So we're going to quickly get a C-collar on the patient, a spine board underneath the patient, turn the patient and pull the patient out of the vehicle. So that would be an example of an urgent move. So the difference between urgent and emergency move is an assessment comes before the urgent move. There is no assessment before an emergency move. There is danger, so we need to move the patient quickly. So rapid extrication technique should be used only if urgency exists. The patient can be moved within 1 minute. This technique increases the risk of damage if the patient has spinal injury. So it's a last resort. Look at all options before using an urgent move. All right, now non-urgent move is very straightforward. So this is any technique that is comfortable for you and your patient and your partner and the patient, right? So it is when your patient is stable. So we have time. We're not in a hurry. The patient is stable, probably doing a routine transport, and we need to transport them from the hospital to wherever they're going to do the routine test and then take them back. We have time now, can work it out and come up with the best method. Or the patient is stable, right? I have various techniques, various. So use when both the scene and the patient are stable. Carefully plan how to move the patient. Team leader should plan to move. Personnel obstacles identified, equipment, procedure, and path. Choose between direct ground lift for patients with non-suspected spinal injury or supine, patients who need to be carried over some distance, EMT stand, side by side to lift and carry the patient. So you can lift the patient directly from the ground. They call that the direct ground lift. You have the extremity lift for those patients with no suspected spinal injury who are supine or sitting, helpful when the patient is in a small space. One EMT is at the patient's head and the other is at the patient's feet. Coordinate moves verbally. You have direct carry. Move supine patient from bed to stretcher using a direct carry method. Draw sheet method. Move the patient from the bed to the stretcher using a sheet or blanket. I have a scoop stretcher or orthopedic stretcher. And it's a stretcher that is very useful for patients that are heavy. It's a stretcher that is very useful for patients that you cannot log roll. So it's a stretcher that can be pulled apart, has two sections that can be pulled apart, one on the right side of the patient, one on the left side, and then you lock the device underneath the patient. And you have scoop backboard and you have the scoop stretcher. The scoop stretcher is metallic. The scoop backboard looks like a backboard, but it can be pulled apart into two equal halves. Now, geriatrics. Most patients transported by EMS are geriatric patients, especially in private ambulance settings in Jamaica. Skeletal changes may cause brittle bones, rigidity, spinal curvatures that present special challenges. Allay the patient's fears with a sympathetic and compassionate approach. So they may have kyphosis and spondylosis, which is abnormal curvatures in the spine. So we may have to do some padding for spaces on the stretcher. We may have to put them in a recovery position. You do what is best for your patient. We'll backtrack a bit. Okay, bariatrics. Bariatrics refers to management of obesity. 76 million US adults are obese. 30 to 40% of adults are obese. Approximately 17% of children are obese in the United States. Back injuries account for the largest number of missed days of work. Stretchers and equipment are being produced with higher capacities, so they have specialized bariatric stretchers and specialized units for bariatric patients. It does not address the danger to users of that equipment. Mechanical ambulance lifts are uncommon in the United States. Now, additional patient moving equipment, and this is a bariatric stretcher, specialized for overweight or obese patients. It has a wider wheelbase for increased stability. Some have a tow package with a winch. It is rated to hold 850 to 900 pounds. A regular stretcher maximum is 650 pounds. You have the pneumatic electronic powered wheel stretcher, quite nice. Battery operated with electronic controls to raise and lower the undercarriage. Perfect stretcher. Increases the weight of the stretcher, hazardous in uneven terrain. You have your portable folding stretchers, which you'll see this one a lot in Jamaica, especially at football matches. The JDF have some of these as well. It's a strong rectangular tubular metal frame with fabric stretch across it. May be necessary when you based on distance and the terrain, so you cannot move your wheel stretcher to that point, so you may have to put them on the folding stretcher and get them to your wheel stretcher. All right, now the flexible stretchers. Excellent for storage and carrying, conform around the patient sides, useful for confined space, uncomfortable but provide support and immobilization. Then you have your short backboards and your KED, which is your Kendrick extrication device. Now, short backboards and KEDs are indicated when you have a patient in a motor vehicle accident. The patient is stable, but they're unable to move on their own, right? And it's being phased out as well, but it's still a part of the curriculum. So I will teach you how to use it, but they're moving away from the KED. They're moving away from it, right? But we will discuss that further down in the course. But its indication is the patient is responsive, suspected spinal injury, but they cannot move by themselves. Now, vacuum mattresses are quite useful for the geriatric and pediatric population. It's an alternative to backboards for immobilizing geriatric and pediatric because it conforms to the surface of the patient, and as we get older, the skin becomes more susceptible to injury. So placing them on a rigid surface can also lead to skin damage within 30 minutes. And the younger pediatric patient, their skin surface is also delicate. So we tend to try and avoid putting them on rigid surfaces. Air is removed from the device, allowing it to mold around the patient. Provides immobilization, comfort, and thermal insulation, which is very important to these patients because, again, geriatric patients, as they get older, their thermal regulation mechanism doesn't work very well, and young pediatric patients cannot regulate their body temperature very well either. Now, the basket stretcher. It's a stretcher that is very useful, especially when you have a patient that is at the bottom of a hillside. So it's a rigid stretcher, also called the Stokes litter, used for patient removal in remote locations, including water rescues and technical rope rescues. If the patient has a spinal injury, secure the patient to the backboard and place it inside the basket stretcher to carry the patient out of the location. Once you move them to where the unit is, you can take out the backboard from the basket stretcher and put it on your wheel stretcher. And this is your scoop or orthopedic stretcher. But the scoop backboard is now heavily favored over the metal type. And scoop backboard is the future. That's the way forward. So if you're working in an organization and you don't have a scoop backboard, start lobbying for that. Start to have discussions with the supervisors or superiors in terms of getting that on the unit. It's going to be the way forward, a scoop backboard. So the scoop stretcher splits into 2 or 4 pieces. The pieces fit around the patient who is lying on a flat surface and then reconnect. Both sides of the patient must be accessible. The patient must be stabilized and secured on the scoop stretcher. Now, neonatal isolate, sometimes called an incubator. Neonates cannot be transported on a wheel stretcher, so the isolate keeps the neonate warm and protects the child from noise, draft, infection, and excess handling. The isolate may be secured to a wheel ambulance stretcher or freestanding. All right, now decontamination. Decontaminate equipment after use for your safety, for the safety of the crew, for the safety of the patient, and to prevent the spread of diseases. Patient position. Proper position depends on the chief complaint. Patients with head injury, shock, spinal injury, pregnancy, and obese patients need special lifting and moving techniques. A patient reporting chest pain and respiratory distress should be placed in a position of comfort, typically a Fowler or semi-Fowler position. So it's not flower position, it is Fowler position. Patients in shock should be placed supine. Patients in late stages of pregnancy should be positioned and transported on their left side. Why would that be important though? Why do I need to transport a patient in the late stage of their pregnancy on their left side? Any bright spark know the answer to that question? Why would that be important? Anybody have an answer? No thoughts?
The organs function better.
The organs function better. Not quite. Anybody else? So think about circulation. I'm giving you a hint now. Think about circulation, specifically the blood vessels. Why would I need to transport a patient that is close to delivery on their left side?
Breathing
No thought.
control.
No, it has nothing to do with breathing. I said circulation. Circulation. Okay.
You want more blood flow to the side that the heart is?
You want what? Blood flow to the side where the heart is? All right, so it comes back to the direction of blood flow within the blood vessels. Which blood vessels carry blood towards the heart? That's a question. Which blood vessels carry blood towards the heart? That's a question that I would like to be answered. Which blood vessel carries blood towards the heart? The veins, right? So the veins will eventually merge into the vena cava. And which side is the venous system on, right or left? Is it on the right side or the left side? I say left, I say right. So someone will confuse. Now play hopscotch. It's on the right side. Yes, on the right side. So if a pregnant patient that is close to delivery is lying flat on her back, the uterus is going to come down, right? The weight of the fetus is going to move downward and compress the veins that are supposed to be returning blood to the heart. So it can actually decrease the venous return and cause the mother blood pressure to drop too low. That is referred to as supine hypotensive syndrome. So we will transport them on the left side to ease pressure of the venous system. Y'all need to learn your circulation. It's not solid yet. An unresponsive patient with no suspected spinal injury should be placed in the recovery position. Why would I need to put an unresponsive patient in the recovery position? I know there are persons here who have done first aid and BLS, yes? So you're familiar with the term recovery position. When is it indicated? Can anybody answer that question? Okay. So one response to prevent ear blockage. I think that covers it. All right, so the recovery position, if the patient is unresponsive, the tongue is gonna fall back and close the airway or obstruct the airway if the patient remains supine. So as long as the patient is unresponsive and they have good chest rise with no indication of a spinal injury, placing them in the recovery position is fine. A patient who is nauseated or vomiting should be transported in a position of comfort. Obese patients should be positioned the same as patients with similar conditions. However, you might want to consider raising the head of the stretcher for your obese patients, especially if you need to do some airway management. Right? We'll discuss that further down. Excuse me for 1 sec. Oh, yeah. My voice is going. All right, now medical restraints. Evaluate for correctable causes of combativeness. So you may have to restrain a patient. Now it can be that because of the injury or medical emergency that is occurring, the patient is combative. Or it could just be a patient that is aggressive. So you need to follow your local protocols. Restraint requires 5 personnel or more. And if you are not properly trained in the use of restraints, then you shouldn't be doing it. Right? So all 4 limbs of the patient need to be controlled, and somebody needs to control the head of the patient. And it has to be the strongest person that controls the head. You want head control, and you want it as soon as possible. If you can control all 4 limbs without any issues, then the head control is not necessary. But if that patient is still giving problems, they need to get control of the head. If you have control of a person's head, any direction that the person's head go, your body will follow. So if I get control of your head, any direction I pull your head, your body has to go in that direction. When you're controlling limbs, you have to ensure that you have control of the wrist and elbow joint. So if you don't have joint control, you're going to be pulled all over the place, right? So if you grab a limb and you don't have control of the wrist joint and the elbow joint, specifically the elbow joint, if you don't have that elbow joint locked in an extended position, you're going to be pulled all over the place. So again, if you're not trained in how to restrain a patient, you shouldn't be doing it. And anybody that is going to be a part of a team that is doing restraints, you cannot be somebody that hesitates, right? Because we need to jump on those limbs in a synchronous manner, right? So I can jump on one limb and the person over there, so I wonder if he will jump on the next limb. It doesn't work like that. So the same time he jump on a limb, person over that side is supposed to jump on a limb too. We need to attack that patient at once. Attack is a strong word, but we need to get a control of the patient's limbs as close to synchronous manner as possible. All right, and you will be guided by your protocols. And as I say, you might need more than 5 personnel. And you have some patients that are very strong, right? I had a patient in Texas, ex-football player, that started to have a brain bleed, and he became very combative, extremely combative, and we had to initiate physical restraints before he could get the medication restraint. And all I had control of was one of his legs. So that was my task. I was given one of the legs, one leg, right? One leg. When I got home that night after completing that particular shift, I was exhausted, right? I was exhausted, right? Tired. So these patients can be very strong. And I had good control of his leg. And even when I had that knee, because I had his leg, the foot and ankle was under my left arm, and then I locked up his knee, and he was still able to flex the knee at times and pull me forward before we could get it straight to strap it down on the bed. And even when it was strapped down on the bed, he still have to be putting pressure on his joint until the doctor that was supposed to give the medication arrived at that particular hospital. So they can be very strong, very strong. Now, restrain the patient in a supine position. So we should never, never, ever restrain a patient face down. That can kill the patient, right? And we saw what happened to George Floyd. We saw what happened to the guy that they strangled outside of the store and put him face down and he passed out, right? So if the patient is face down, their chest cannot expand properly, and that's gonna affect their ability to ventilate, and eventually they're gonna lose consciousness. And as I said, the George Floyd case is a perfect example of that. He was in the prone position until he got to the point where he started to have trouble breathing, which he was verbalizing until he went unconscious. Right? So don't restrain a patient in the prone position. Apply a restraint to each extremity. Assess ABCs, mental status, and distal circulation after restraints are applied. Document all information. All right, now personnel considerations. Questions to ask before moving a patient. Am I physically strong enough to lift and move this patient? Is there adequate room to get the proper stance to lift the patient? Do I need additional personnel for lifting assistance? Injured EMTs cannot help anyone, right? So a dead EMT cannot help anybody, and injured EMT is a nuisance. So always protect yourself, right? Personal safety first. And that would be the end of lifting and moving patients. Are there any questions? Okay. No questions. Go ahead, Mr. Duhini.
Just confirm, okay? If we are on dispatch and we arrive at the scene and there's, say it's a falling building or so forth,